It's Dr. Cassie Smith, and welcome to Back to the Basics, a simple approach to health in the modern world. I appreciate you taking the time to join me today and hopefully learn ways that could help you improve your health. The modern world has left little time to focus on health and wellness. I hope to give you some quick and simple ways to be well and live your best life. Welcome back to this week's episode of Back to the Basics. I'm so happy that you decided to join me today. I'm super excited about our guest, so I'm so pumped. Dr. Nathan Goodyear is here to talk to us today about cancer. So I know you guys have reached out to me about different things. I do a lot of stuff with cellular health, and so he is on the same wavelength as I am. So he believes in trying to prevent things and actually fix things without putting other toxic things in our bodies. And so Dr. Goodyear's passion for wellness began with his own 100-pound post-college football career weight loss. He works with Dr. Jason Williams at the Williams Cancer Institute, an innovative, integrative cancer center with offices in Beverly Hills, Cabo San Lucas, and Mexico City. Together, they're working to innovate, elevate, and empower the next generation of integrative practitioners for patients in the future of cancer care. It's not enough to target and eliminate cancer. One must focus on healing. The best answer to cancer is to never get it. Dr. Goodyear is dedicated to disease prevention, all disease resolution, and to the wellness lifestyle through a solution-based, holistic, integrative approach founded in science. Dr. Goodyear, together with Dr. Williams, is working to reprogram phenotypically diseased cells instead of waging war. So, as you guys know, I'm very passionate about this as well, so I'm so happy to welcome Dr. Goodyear to our podcast.
Cassie, it's an honor to be with you.
Oh, well, thank you. So right before we came on here, you guys, we were just chatting a minute, and Dr. Goodyear is actually from Enid, Oklahoma. So he actually grew up close to me. He was telling me how it was in the middle of nowhere. I have a lot of patients from Enid who might take that offensive, but he grew up in Enid, and so he's a fellow Oklahoman. I'm hoping a boomer sooner, but we don't have to talk about that. We don't need to make anyone upset. But he grew up in Oklahoma, and so I was just telling him how our clinic was about to be done, and we were going to do some cool, innovative stuff. And so I was trying to entice him to maybe come and see us. But I want him to tell you guys a little bit about himself. I think it's really cool how he got into this field and kind of his background. And then we're going to start picking his brain because he is a wealth of knowledge.
Well, do you want me to call you Dr. Smith or Cassie?
No.
Okay.
Please call me Cassie.
Okay. Well, wow. So life's a story, is it not? And I'm sure you have a story, and it's one that connects with people clearly. And that's why you have so many patients. And that's why you're doing such a good job in terms of allowing people to pivot from the idea of disease focus to one more of a wellness-centric model. And that's what's desperately needed today. When I went and played college football, within 5 years after I finished, there were I actually played offensive line. So I played at about 285. I think I had a 54 jacket. I was huge, 23-inch neck. We played Oklahoma State, Auburn, Alabama. Great opportunity. But two of the guys I played offensive line with died within 5 years, cardiovascular events. So when I was in residency I was OBGYN. Our focus was on gynecological surgery, primarily pelvic surgery and reconstruction. But I was like, well, I want to be in wellness because I recognized that disease was a reactive process, and I wanted to be proactive for our patients. And I had a young fledgling family, and I wanted to be there with my family. And so I started focusing on weight loss and focusing on how to get into the arena of wellness. And so then once I got out of residency and got into private practice, I started to discover that some of what we taught didn't exactly work, meaning some patients would benefit. So as a gynecologist, you kind of went through this strategy of, okay, let's put you on birth control pills. Okay, let's put you on hormones. Okay, let's do an endometrial ablation. And then, of course, we have that evil humorous uterus, so let's just take it out. And that'll solve all the problems. And clearly, a uterus just does what it's told. A uterus is not sitting there scheming in how we can just make life miserable for a woman. It's the environment. It's the hormones, of course, you understand. It's the inflammatory process. It's all of it together that comes together to create an environment that allows things to miscommunicate. And that's what we see manifested in so many aspects of women and, all the bleeding issues and hormonal issues they see. So I started to discover that we could help some people, but we couldn't help everybody. So that's what began my transition into this wellness movement. It began in 2006. And anytime you get into hormones as a OBGYN, I thought hormones were defined as, men are an estrogen-fueled erection and women are an estrogen-fueled hot flash. And I found out really quick it was much more than that. But I started to say, you know what? All these patients that are coming in for hormones, they have an issue that they're concerned about cancer. So I better really know the impact of cancer, whether it's their history or whether it's their potential risk. Then as I was taking care of the women, they said, hey, you've taken care of me. Can you help my husband? He needs a lot of help. And so at that point, I had actually had an issue related to the pelvic floor mesh many years ago. And I know I'm getting long-winded, but I think it's relative here. It's important to the point. But I told the women that I will study this issue for 6 months. And then if I feel comfortable, I will go ahead and start treating the men. And so I did, and I wrote a couple books out of it. And men are actually much harder to treat than women. They're the most hormonal of the two, for sure. But at that point, so much of my patient population was related to cancer because they were taking hormones or they were wanting hormones, and there was risk before or after. So I moved into the full wellness movement, got out completely of OBGYN, and half of my patient population was cancer. Now, it was more, I was working alongside them. They were going to the conventional oncologist. That was until I was diagnosed with my pheochromocytoma, my malignant one, in 2016. And that was really the transition point for me. And so I knew that was my calling. I was already out of the conventional model and had been since 2008 and had been doing all things integrative for a long, long time. Moved out here to Arizona, where we do have a much more open strategy, as I'm both a licensed MD and a licensed MD homeopath. And that for the last 6.5 years, I've basically been doing nothing but integrative cancer. And it has been the best 6.5 years of my life. And so that's, in a synopsis, my journey that brought me from conventional medicine to integrative medicine.
I love that. So I think, we all have stories, you're right. And my story, thankfully I've not had cancer, but was how yours started. We learn stuff in school. I go to fellowship. I learn everything there is to know about diabetes and weight and metabolism and thyroid. And then you practice that. And just like you said, some people get better, but a lot of people don't. And I was seeing that there's this disconnect between what we learn and what actually happens, right? And I'm the same way as you. I'm like, something's not right. And so this miscommunicating environment, I like that. There's a miscommunication in the environment where some people are getting better, some people aren't. And I'm very much a proactive, not a reactive person as well when it comes to disease. Like, I love, people that come to me and say, I just don't want to get sick. What do we do? And you're right. When you start doing hormones, the biggest scare everyone has is cancer. And so I think that's why you intrigue me so much, because I have a conversation with a woman at least 4 times a day about how if you do bioidentical estrogen and testosterone in not crazy doses, it actually doesn't increase your risk of cancer. It actually lowers it. And so anyways, I have these conversations, and it's just traditional medicine and oncology scare people, right? The C word is like, oh my gosh, you have cancer, but they don't talk to you about like, well, 1 in 4 women are going to develop breast cancer. We cure breast cancer 92% of the time in this country. What does chemo and radiation do? What are your other options? We don't give people choices. It's like we're all unfortunately programmed in this world to, like, in med school, they say this square, person fits in this square box. Well, it doesn't always work like that. And so I like that you are kind of outside that headspace and that you are somebody who wants to help people do more holistic, integrative stuff. So
yeah, we're in a new world. We're in a world of precision medicine, right? The one size fits all approach no longer applies at all.
It really doesn't apply hardly at all. I mean, you're right. I see, 20, 22 people a day. And if you try to put all 22 people in the same plan, none of it is working. And I think that's almost why I like my job so much too. Like you said, I kind of am getting out of the whole insurance whack-a-mole and doing more and more integrative functional stuff. And it's so cool, right? Because people actually get better and you actually use your brain. Like I'm tired at the end of the day, my brain hurts, but it's so cool because if you give me enough information, cellular information, testing, and you let me try enough things, I really think I can fix anybody. Like, right? I mean, if they'll listen and participate in their care, if you go back to the basics, which is why I started this podcast, if you go back to cellular, physiology, and you go back to ATP and Krebs, and you go back to the phospholipid bilayer of a membrane, and you go back to how all these signals, mTOR and interleukins and tissue necrosis factor alpha, how they all play with your immune system plus hormones, like you can figure it out if you just think about it, right? But that's not what they teach us in school.
Yeah, well, they just teach us, what pill to give and what thing to cut out, and that's really it's a what I call protocolology. It's a form of medicine that's just a collection of protocols, and in that way, it creates we can get a little bit off track here, but it creates a system that can be managed and controlled, and the profits can be steered. So completely outside of the scope of what we're talking about here, but that's part of what's wrong with medicine is the focus is no longer on the patient. It's all in controlling the template. It's all in controlling the environment in which the commodity is moved. And the commodity is us. It's people. And so people that are stepping outside of that box are going, no, 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 no. My job is to serve the patient. That's who I serve. And so when we step outside, and you may have seen this already or may not, you're basically affront a little bit to that system. And so the more doctors that do that, the more stress and strain on that. But here's the good news. The patients, the bulk of the patients, they're already there. They are the tip of the spear that is basically steering this change in medicine. Medicine is in such a fulcrum point at this junction of history, and that's why it's so unstable, it seems at moments, because it's in a flux of change. But it's going to be a good change. It's going to, I think, restore power to the patient. I think it's going to provide a balancing out of the problems that we've had over the last 100 years. And I think it's going to take us back to our original purpose, which is getting back to healing the patients.
Yep. I completely agree with that. I love it when patients come to me and they say, I saw a couple new people today. I don't want to take any more pills. I want you to tell me what's wrong with me. And I'm like, great, then you're in the right place. Because if you want a bunch of pills, you can go down the street, like that's, yeah. And so I do love that. But, it's hard, right? So it is hard to listen to somebody and to think about it and to get the labs and to stay up to date with the research. And I mean, you have to use your head. It is not cookie cutter medicine. And so I don't mean to say this to sound mean but like a lot of doctors don't want to do that. Like, right. They're in the zone. They drink the juice. This person A gets a square pegs, a square box or a square, this person fits in a square hole. Like nobody is changing things. And so that's unfortunate, but I agree with you. I think people are going to start asking and wanting, and we have the information, the knowledge to fix stuff now, which is what is so cool. And like, I seem to think I'm pretty cutting edge and try to stay up with stuff. But then I went to this conference this last week and I went to an international peptide conference. And I was just sitting there the whole time with my mouth open, like literally for 16 hours. I just sat there with my mouth open and I was like, there's so much cool stuff out there. Like, I love that. I love when I feel really stupid. Like, cause I'm like, it motivates me to go learn more stuff, right? I'm like, why do I not know this for my patients? And so I think that is what's so cool about what you're doing and people are doing is, there are other options and people just need to know what those options are. And then we need to talk about how do we fix things at a cellular level, instead of giving people things that cause more side effects or that just cover up symptoms, right? That don't fix it.
Right.
So
when you bring it to the concept of war, on cancer, it's war on cancer. I mean, that's kind of been the working strategy the last 75 years or so. In fact, Nixon declared war on cancer in 1971. And it's really interesting because that process of going to war on cancer has literally laid waste to millions of bodies as the battlefield. I mean, that is the context. And we have to change that. We must recognize that the person in front of us, yes, has cancer, but it is not their entire body. We must look at the environment, look at the immune system. And by the way, the answer is the immune system, and really work to target the cancer and not the body. This idea that, well, let's destroy you. And on the other side, let's hope that healing is there. And the average person goes, that really doesn't make sense to me. But that's the modus operandi that we've been under the last 75 to 100 years.
So true. I agree. It's the immune system. And for all my patients out there listening right now, this is why I tell you to take your vitamin D and we talk about your immune system. But anyways, so tell it, do you care? So you said you had a malignant pheochromocytoma, and this, like, you know, as an endocrinologist, this is crazy because it's a very rare cancer. And you're told in fellowship, like, you might see one of these in your whole career as an endocrinologist. Like, this is not normal. And if you do, you know, I've actually already seen one. So I've met you. I haven't seen, but so you're number 2. But how did you figure this out? Were you having like the palpitations? Was your blood pressure really high? Tell us what happened. And then obviously a malignant. So just so you guys know, listeners, you can look it up, type in malignant pheochromocytoma into Google. It's usually not a great prognosis. So he had it in 2016 and he's still here in 2024. So obviously he did something right, but tell us like how you figured this out and what happened.
I wasn't a good patient, as most doctors are not. I was a runner, and there were a couple of days where I went out and ran. And the first day I went out and ran, we were in Tennessee at that time, and I had to stop because my head started pounding. And I had to call my wife and tell her to come pick me up. I wasn't far from the house, but she did. But, you know, I'm a guy and I'm stubborn and I'm a doctor. So the next day, what do? I go back out and do the same thing. And I end up in the exact same position. But this time the pounding was, you know, much, much worse. And I had always had just completely perfect blood pressure, you know, like 118 over 62, you know, just incredible blood pressure. I was about 178, 182 pounds at that point. And so the next morning, well, actually that evening, I noticed my eyes were bloodshot. And, you know, like I'd busted all my, you know, just blood vessels in my eyes. So that next morning I went into the office and I just thought, let me check my blood pressure. Well, it was like it was 300 over 122 or something like that. I mean, it was stupid. It was stupid. And then I thought, well, this is odd. And so over the course of a couple days, I got some labs back, noticed my hemoglobin A1C was 7.2. You know, it was just like, okay, this is not adding up. So at that point, I started, researching as to what could cause this, and went and, of course, got a head CT that turned out to be negative. And then a good friend of mine is by the name of David Zava. He owns ZRT. And so I did a neurotransmitter test, and amongst of many other things that I was doing to try to figure it out. And I got a call one day, and they said, David wants to talk to you. I said, okay. So I waited on the phone. He got on there. He said, hey, Nathan, are you okay? And it's like, I'm okay. Yeah. It's like, what's wrong? He's like, I think you got a pheo. And I said, I think so too. And so at that point, I actually reached out to my doc and I said, I think we need to look at some of those more just kind of, you know, you're not supposed to get them, but you see them on a test question. And so sure enough, that's what happened. And at that point, the surgeon was a great surgeon. He said, it's quite enormous. It does look like it's outside of the tumor, but let's go in. If it's what I think I see on the CT, then I'm hoping I can get in there and get a lot of it. Fortunately for me, he was able to get in there and it was outside, but he did get all of it. And knock on wood, I've been okay ever since. But it was a really interesting process being in that position because it hasn't spread. I've actually seen it in another patient as well, a 32-year-old that had it all over the place. He was actually diagnosed with a benign pheochromocytoma a few years earlier and then presented with it malignant. Mine came back from pathology as malignant. So, but they had it, and to this day, I'm still good. But that morning the next morning when I was in the ICU, it's always odd to be kind of in that position where you're in the bed and the anesthesiologist comes in. And the first thing he tells you is, "Wow, I don't know how you didn't stroke." And then the surgeon comes in and he goes, "Wow, I didn't know how you didn't stroke." And I was like, "What do you mean?" So in the surgery, apparently my blood pressure went just like stupid. And they had to rush really fast to try to clamp off its blood supply. But for me, it was an opportunity to learn. And it was an opportunity to change. Because if you looked at me at that point in life, everything about my physical appearance was healthy. Everything. But inside, it wasn't so. And so it was kind of one of those things that, because most of those are benign, but then when he said, no, this was malignant, I was like, oh goodness, what do I need to do? He said, I got it all. He said, I think you're lucky. But so we had follow-ups and everything has turned out okay up to this point. So, it's kind of one of those freaky things sometimes you see in cancer where somebody just goes in for a laparoscopic tubal ligation and they have ovarian cancer. They find it, they get it out, and they're fine. So, but I think it's an opportunity that I was blessed with to actually position me and pivot me to do what I do today.
And to have more empathy for patients. Sometimes I joke that some of the best doctors have been those patients before. So if you deal with people with cancer, you know what that scary word. And so for listeners, I'm sorry, a pheochromocytoma is when your adrenal gland makes some important hormones. Some of the hormones that it makes, and your adrenal gland sets by your kidneys. So you have two of them. It sets on top of your kidneys. They make catecholamines and metanephrines. And these are kind of things that are supposed to help regulate your blood pressure, but like if you see a lion, you run type of thing. So it's something that just kind of helps regulate blood pressure. When you have a pheochromocytoma, your adrenal gland makes too much of this all the time. And so basically you get these wild blood pressure swings, like super high blood pressures. You get headaches. And so sometimes how we find these, unfortunately, is post-operative or post-autopsy. Somebody goes in for a typical surgery, a gallbladder removal, something like that, and they die under anesthesia because their blood pressure gets very high. And then you discover this after the fact. Oh crap, they had a pheo. They were releasing all these hormones and it made their blood pressure high and they stroked out. So that's why his blood pressure was 300 over 122 and he had these bloodshot eyes. And this is why the anesthesiologist and the surgeon were shocked he didn't die during surgery, because these things release these really bad hormones that cause your blood pressure to be really high if they're over releasing them. And so, so that's pretty crazy. I'm glad you didn't die. It's interesting that you didn't really have any symptoms until you did. So I do have lots of questions. I do think, yes, you got this. And so now you can be more empathetic with cancer, I'm sure. And you can talk about how you felt when somebody said the word cancer. But I think you bring up a good point. So you had this malignant tumor that had left the outside of your adrenal gland. So now it's in your whole abdominal cavity. It's malignant. That's why it a lot of times is not good. But they took it out and then you haven't had a recurrence. And so it kind of goes to show you that, okay, first of all, it's kind of cool to think about your body had mutated all these cells, right? And made this cancer, but you were still functioning. Didn't really have symptoms until it got pretty bad. And then to kind of think about, okay, well, they removed it. So then what did your body have to do from an immune point to make sure that your body went in and autophagized or ate all the cancer cells that were left? Because there's going to be microscopic cancer cells left no matter what, right? Every time you have cancer, I don't care what kind of cancer you have, people. I don't care how good your surgeon wants to make their ego feel and tell you that they took every single cancer cell out that there was. They didn't. I promise. There's microscopic ones elsewhere. Your body, your immune system is helping you, helping that surgeon's ego if that's what they told you. And so it's interesting to kind of think about, like, what did you do post-cancer to help your immune system? What you're talking about, changing your environment, changing your insides. So tell us, what did you do, Dr. Goodyear, after you had this cancer so that you could make sure that your immune system was functioning the best possible, as best as it possibly could, and that this doesn't come back.
So, Cassie, you touched on some really good points there, that when patients are told they have no evidence of disease, that is a wonderful place to be. But the issue is, it's just determining that we can't see something per our latest technology. That's imaging, that's labs, that's examination. That doesn't mean there's no cells there. And in fact, when you look at surgery, when you look at chemo, when you look at radiation, the pillars of modern day conventional therapy, they spread the cancer cells. I mean, the literature is very clear that surgery kicks tumor cells out. Circulating tumor cells spike. It suppresses the immune system. This is why you can see patients have local recurrences actually at the site of surgery. It's because of that mechanism of action. And then you add in anesthetics and other issues. So cancer is a cellular I look at it as a cellular adaptation to an inhospitable environment. And there's a lot of things that go into play for that. In the short term, when you look at a cancer cell, you go, well, that's actually kind of a good thing that a cell adapts to survive. And it is. But in the long term, what happens is it starts to, evolve. It starts to mutate. It starts to metabolically shift. And it starts to gain advantages over its environment. And then it starts to manipulate its environment. It's like the ultimate bully. It really starts to draw people in and then turn these immune cells and other cells on the other cells around it. It is the ultimate, I look at it as the ultimate autoimmune disease, because it uses the immune system against the immune system in many aspects. So you have to, once you're diagnosed with a cancer, you have to recognize that there is always that immune dysfunction that exists. And there's always that propensity to basically get back in that line. So for me, it was about lifestyle, because cancer itself is a prospect that results from lifestyle for the most part. Now, we have a lot of issues related to epigenetics, transgenerational epigenetics of pathology. So this is why we're seeing the accelerated increase in incidence of cancer. But when you look at a study from 2019 in the Lancet Journal called the Prospective Urban-Rural Epidemiology Study, it showed that actually in high-income countries, cancer was the number one cause of mortality in adults, not just by a little bit over cardiovascular disease, but at a rate of 2.5 to 1. So the issue of cancer is a real issue today for our generation and for future generations, and it's going to only get worse. The way it originates is lifestyle, and that's in turn what we're unfortunately passing on in the legacy of our kids. Everybody focuses on debt, and rightly so, but a legacy of disease and cancer is another legacy that we don't really want to pass on, but we are. And so we can equally, though, combat that with lifestyle. And when you look at what the last 100 years have brought, it's been, well, let's go to war on the cancer. And as that, that was the problem. But now there's so much exciting research, and what you see in the lifestyle management, whether that be nutrition, plant-based, I'm not afraid of meats, but it needs to be clean meats, regular exercise, good sleep, of course, targeted supplementation, relationships. People don't talk about that. Relationships. My wife and I have been married for almost 32 years. Family, church, these kind of things that help to encompass and bring together the environment in total are really what help us to live well or live with disease. And I tell people, living for disease is a choice, just as living for wellness is a choice. So now you're starting to see in the literature, because epigenetically we've seen what lifestyle can do, where people are going, wow, maybe cancer cells, we don't just go to kill them. Maybe we can reprogram that environment. Maybe we can actually, if things shift one way, can they shift back? Where you're actually using the inherent healing processes of the environment, you're actually able to use that to the benefit against the cancer. And I think that's where the future is coming, where we're actually now going to be looking at reprogramming, not necessarily killing. And that will be a welcome strategy, I think, for people. We're a long way from where we need to be for sure, but it's been a few weeks. The last time I looked on PubMed, there was well over 18,000 studies looking at reprogramming and cancer. So it's an exciting area, and it's one that I think is going to really change the way people think about cancer and the way people experience treatment with cancer if they are ever diagnosed. But I think the key is not to just use this new area of research and discovery to actually treat cancer, but it's to prevent. It's to prevent cancer.
So, yes, I love that. And so for me, I'm always that person who, ever since I was a little kid, I want to know why. Or like if things don't make sense to me, I ask why. So for me, I talk to a lot of women about breast cancer, right? Unfortunately, it doesn't make sense to me, no matter what kind of cancer you have, to say, okay, you've got these cells that have mutated, right? We know those cells were normal at some point, but they've mutated, right? So they've done something different. Let's go and just completely obliterate those cells. Let's kill them. But in doing so, let's kill all of your good cells too, right? Your immune cells, your gut, let's just give you chemo and radiation and kill every cell in your body. Let's kill all of it, even though we're just trying to kill a microscopic amount of cells that have reprogrammed themselves into something else so that you feel absolutely terrible. And in doing so and in killing all that cancer, we're going to take your appetite away. We're going to make you nauseous. We're going to make you not want to go outside, not be around your family and friends, not eat the nutrients that you need. All the things we know that will help your body heal and fix itself. Let's just do that. And then hopefully, like you said, we'll get through that. And then, 6-8 months from now, hopefully you won't have the terrible side effects that obliterating all the cells in your body gives you, right? The numbness, the tingling, and then hopefully your cells will go back to normal. But in my mind, I'm like, okay, if we're putting these toxic things in our bodies, these chemos, these radiations, you're disrupting your entire body's environment now. So who's to say that when those cells do actually grow back, because we've just obliterated all of them, they're going to grow back normal? Because now you've put this toxic whatever in your body. It's almost like a radiation, right? So the people that are around after a bomb is dropped, like in Hiroshima, those people weren't normal after all that radiation, right? So why do we think that it is okay to drop a toxic bomb into somebody to treat this tiny little area of cancer, when instead we should be saying, okay, how do we get that little tiny area of cancer to reprogram itself, or to just let's autophagize that. Let's go and take it out. Let's take out what we can. And then let's get the cells that are there to go and eat what they shouldn't eat. Let's let our immune system do what it was made to do, right? Let's go have our macrophages and let's get rid of the cancer. And then let's make sure that all the other cells that we have the nutrients they need, everything they need from a cellular perspective, however else we can help our immune system get better so that then the rest of our body heals itself and kills what's left. Like, to me, that makes more sense, right? Like, if you've got a little spewing problem, you go fix the spewing problem. You don't drop an atomic bomb on the entire city. Like, to me, that just never made sense. And so I'm glad I'm not the only one in that boat.
It's like you go in and, you need to change the oil in your car, and they go, okay, we're just going to take a sledgehammer to your car. And it's like, well, that doesn't really make a lot of sense to me. Now, I want to say this. Surgery helped me, okay? There are points where conventional medicine helps people, but there are equally more points, I believe, where conventional medicine destroys the immune system. And that's the key point. You brought up the point of radiation and looking at Chernobyl. I was talking to a patient just the other day that was 70 kilometers from Chernobyl. And no surprise, she has cancer. But radiation is interesting because it's a paradox within a paradox within a paradox within a paradox, because radiation causes cancer, yet radiation is used to treat cancer, yet radiation causes cancer to spread, and yet radiation can actually cause cancer to return to the site of radiation. So it's a really odd mixture of how we use radiation. Now, you can use it very fine point, very pinpoint, and really try to mitigate that effect, but there's still negative side effects with that. The ultimate negative effect, I think, comes with full dose chemo, where what you see massive immune destructive, massive. And in fact, the literature clearly says that when you look at the CD8 cytotoxic T cells, they may never recover. They may never recover. And so if they don't recover, then your immune system has never reached its ability to do its job. So that means if you did not get all those cells, guess what? Your immune system is now compromised, which means if you're a no evidence of disease, that is fantastic. But the ticking time bomb is moving. And so that's what always irritates me is when people achieve no evidence of disease and then they're in the conventional model and people go, well, I went to my oncologist and they said, okay, so what do we do now? Oh, nothing. What do you mean nothing? How about we build my body up? How about we promote healing? How about we promote my immune system? How about we help my body get back to its optimal function? But it's because the focus is on disease, which interestingly enough, that's two words, dis-ease, which literally means the lack of wellness. And we need to focus on healing. Now, conventional doctors will focus on disease, but once they achieve that point where they can't see anything, they don't know what to do. They don't know what to do because they're not trained to. But that's where we can step in and really help. But also we can help in and treat and not destroy the immune system. I mean, there's no reason for that. There's just none.
Yeah. So conventional doctors are trained on sick care. And so when you're no longer sick, they don't know what to do. And I'm a recovering conventional doctor. So I'll be the first one to tell you until about 2020, once your A1C was normal, I was like, okay, great, your A1C is normal. But I still knew their fasting sugars were higher than they should have been. And I see their lipids are high and they're still gaining weight and their blood, their kidneys are getting worse. Their eyes are getting worse. Their blood. But I was like, hey, your A1C is great. They tell me that's good. So out the door you go, So doctors are trained in sick care. We're not trained in wellness. And, that's, and to make sure that we solidify this point, I completely agree with you. You need surgery if you have cancer. You want to get rid of the tumor burden if you can. So that's not what I was saying. Like if you have a cancer, yes. If I ever, God forbid, get a cancer, I will have a surgery, like get rid of the actual large amount of tumor, as much of it as you can. But then you're not giving me chemo or radiation, people. Like I'm going to see Dr. Goodyear. We're getting on some ozone, some IV vitamin C, mistletoe, whatever he tells me to get on. I'm going to sleep. I'm going to eat. I'm going to get my protein. I'm going to let my immune system do what it's supposed to do. So
let me tell you this, the future of cancer care is going to really change how we approach surgery, really, because, what we're doing and really, Dr. Williams really helped to pioneer this. And that's why I joined up with him, is because of the innovation. Instead of going in and just, cutting everything out, because that does buy time. And there's aspects where, reducing the tumor burden can definitely help when you're using systemic therapy. But if you instead use the tumor against itself by doing intratumoral therapy and coupling that with ablative techniques like pulse electric field therapy, like cryoablation, what happens is you take a localized treatment effect and you actually cause it to move systemically. And so it allows you to target a tumor, not just cut it out, but target the tumor, because I've seen too many tumors that are cut out and it just comes back. You have to change the environment. So that's why going into the tumor with intratumoral therapy, not surgery, but then allowing the immune system to be activated against the cancer allows that message to then be stimulated throughout the rest of the immune system. Novel concept, help the immune system do its job and step back and let the immune system do its job. And here's the novel thing. These patients heal as they have a high quality of life. So they maintain quality of life, many of them, but they heal as that happens. Now, this is cancer, so we have to be honest, this is cancer. Cancer is a brutal disease. Nobody wants it. I wouldn't wish it on anybody, even my enemies. But the way that we've been approaching cancer has propagated the return of cancer. So the paradigm of the future is to change our approach to cancer and use the immune system that's there, the defense mechanism, and let it do the job for us. Let it do the hard work. We just got to get it started. And that's really what these strategies allow us to do.
And it makes sense, right? Because if you're fighting a war, let's think about it. If we're fighting a war, Do you want to give all your soldiers the best, shield, the best gun, the best tanks, the best ammunition, like, the best missiles? Or do you want to, just destroy the whole area? Like, it doesn't make sense to me. Like the chemo and radiation, like you need to give your soldiers, your immune system, everything that it needs to work. And then you need to let it go do its job. If you have a well-trained, immune system or a well-trained army, then what you're going to do is you're going to give the army what it needs and you're going to let it go do its job, right? You're not going to blow up the entire army, which is what we do with chemo and radiation. So, what kills me is when I see these people back, right? Like I saw a couple people this week who are doing chemo and radiation and they are miserable. They look miserable. They feel miserable. And like you said, one of them was almost crying and said, is this tingling going to go away in my hands and feet ever? And I'm like, it may not. Like, well, they told me it would. And I said, well, I don't know who told you that, but it may not, and it's frustrating because I think we scare people and we don't give them all the options. And again, a lot of the medical oncologists are doing what the guidelines say. Is that driven by pharma? I don't know, but it's heartbreaking to me because you end up with a lot more symptoms than you had before you were diagnosed with cancer. You do things to your body that sometimes, like you said, you'll never recover from. And there's better evidence that we need to, let people know and let people decide what they want to do. But from just a regular perspective, like going back to, physiology and just, chemistry and how the body works and how your immune system is supposed to work, obliterating it with radiation and things that kill your entire, GI tract and every lining of cell you have in your body, it doesn't make sense, right?
Well, and in fact, when you look at the immune system, I mean, you have to look at the gut microbiome, right? Because, of course, what we eat and everything about what we're inheriting from our parents, that's setting the stage for this microbiome. And what that does is that impacts the immune system. And so if you're not working within the gut microbiome, and you could be working within the gut microbiome through nutrition. So it's not just that you're necessarily doing, taking a supplement of something. But I would tell you that when you're dealing with something as severe as cancer, the gut microbiome, its diversity, its population is at a massive abnormal level. And so you have to take things to a whole nother level. You can't look at cancer and say, I'm just going to take this supplement and it's going to heal me. Things have really gone off the rails, especially when we're talking about stage 3, stage 4. There has been massive destruction and metabolic derangement within the body, within the immune system, and elsewhere. And you have to really go aggressive. So one of the things we like to do is actually do fecal transplants for our patients, where we actually will work to restore their gut microbiome. And that is very critical. And actually, when you look at the literature, Cassie, it's really interesting. You take the checkpoint inhibitors, Keytruda, Opdivo, these kind of drugs you hear about as people are, running on the shores with nets, catching butterflies, and they talk about how their left leg's going to fall off, But these are medications that can help people. They help to unmask the immune system. So what happens is cancer takes advantage of things that are there. It doesn't really create anything new. So it will take advantage of this immune checkpoint where the immune system wants to not attack the self. And so cancer goes, well, gosh, I can take advantage of that. So if I express that, that means the immune system will come along and not see me. Well, that works. And so that's what it does. So when you look at these drugs, they were presented as the Pansenia some 10 years ago or so. And they have a response rate of about 20-25% response rate, not remission, not complete response, not partial response, just simply response. Could be 10%. Okay. But when you add a fecal transplant to it, you take that response above 69%.
Can you do fecal transplants in the U.S.?
There is actually an FDA-approved fecal transplantation for it's off-label, but it is approved for ulcerative colitis that has failed, not ulcerative colitis, Clostridium difficile that has failed antibiotics. So if it's failed antibiotics once, Clostridium difficile, there is a FDA approved product. It's called Rebiota. Okay. And you know that so many of the therapies we use today are off label, where there's evidence that indicate it's helpful, and we use that. And so, we use that mostly, outside the country or off label for our patients. But if you have Clostridium difficile, hey, it's FDA approved if you failed initial antibiotics.
So I have so many questions about this. So is it a pill that you swallow? Is it a procedure that they do a colonoscopy and give you somebody else's fecal matter? Like, how are we doing these fecal transplants?
Yeah, I would love to see, those pop-up things you would see in cartoons above people's heads. I would love to see what people are imagining, a bag of poop, going, it's not, it's an enema. Okay. It is an enema. Okay. And it's basically microbes. That's what it is. It's basically microbes. It's a great company. Of course, again, they have FDA approval. They cannot say that it's for this indication, but we're using it to improve the immune response, because everything we're doing in the William Cancer Institute and in cancer therapy, so anybody that's out there, they would benefit from this. It's helping the immune system. Now, where we need to go, Cassie, is we need to be precise. We need to be targeted. Okay. And so there are people that are working to design more custom fecal transplants. Okay. I don't believe that, in my experience, that probiotics are going to be enough to change the environment in the gut to have the impact we want. There's only one physician that's ever proven that they can actually cause a acceptance of the body of this new implant. Okay. And that's Dr. Sabine Hassan out in California. And so the ability to engraft these bacteria into the gut microbiome, I think the future is the precision nature of that, the custom nature of that, because we know that there are specific species that are deficient in people that are at high risk from cancer. But here's the connection beyond just the immune system. Research on pancreatic cancer shows that bacteria from the gut seeding the tumors in the pancreas accelerate its aggressive behavior and spread. So now it's not just the gut microbiome, it's now actually the tumor microbiome, and then the interaction and communication between them. So now it's just starting to go, okay, there's a lot here going on that we just don't know. But these microbes, they play a very important role.
Yeah, the gut-brain connection is real for so many reasons. We make a lot of dopamine, serotonin, tryptophan in our gut. This is why a lot of you, so if any of you out there struggle with anxiety, depression, and you have a terrible diet, and if it got much worse after COVID, there is a reason because COVID obliterates the cells in your gut, and then you can't make tryptophan and you can't make dopamine. And then that tryptophan that you do have crosses the blood-brain barrier and there's not enough there, and it worsens your anxiety. I mean, yes, the gut-brain connection is so real. I wish I would have known when I was younger. I'm sure we all do, but in my 20s, I ate terrible. But I try very hard to eat better. And the problem in this country too, I don't know what your thoughts are, but if you look at cancer, I mean, it just keeps going like this in this country, right? And we want to blame plastics, and we want to blame people are obese, and we want to blame whatever. Our food source is so sick in this country. And you're insulting your body 3 times a day with food, at least. Some people insult their body more than 3 times a day with all this crap. And then, yes, you get your microbiome out of whack, and then you can't make your right hormones. And then I'm so with you. And I've been very intrigued with this forever. I want to be a part of the company who's going to make little fecal matters and pills that we can swallow, because I'm all about it. Say what you want. You give me the right fecal matter. You tell me it's going to do great things for me. Down the hatch, it's going. I don't care. I don't know where it's coming from. I don't care, but I'm willing to take it. So that's very, what?
It leaves an aftertaste.
So does apple cider vinegar. It is what it is,
Basically, this functions just as an enema. And again, for sure, there is so much this is where you're standing on the beach and you don't even see a wave. You don't even see the formation of the wave. All you see is the water's just starting to receive on the beachhead. So that's where we are in the gut microbiome as it relates to cancer. You talked about, COVID, the pandemic. One of the impacts that some researchers really pointed to is the destruction of certain bacteria in the gut. And actually, when people talk about certain, quote unquote, repurposed medications, ivermectin, there's speculation in some research that some of its benefit could have been that it was preserving some of the healthy, good gut bacteria. We think about, well, okay, ivermectin's an antiviral. Well, yeah, there's research that shows that. But maybe its effect was actually occurring somewhere else that was actually affecting the immune system, that was actually keeping this immune system more balanced and not allowing it to go into this cytokine storm and just start destroying everything. So we always look at what's right in front of us, that tumor, when actually what we may need to be doing is looking over here and over there and everywhere else and get away from this fixation on the tumor. Now, we still need to treat it. We need to target it, but we need to help the body do its job. And that's just a different approach that conventional medicine doesn't teach.
Yeah, the environment, some things have opened my eyes about environment. Like I've always been very in tune with like hormones and micronutrients and actually cellular health. But when I started doing a lot of research recently on, we'll call it cellular tissue products, and some of the different cellular tissue products that you can use, right, in this country, I think we can call it that. A lot of those have a huge impact on the environment, right? And I was learning about how if you give somebody these and the environment's not right, it doesn't work as well. And just talking about how these things do change environments, and then the environment is what will help the disease process or help, the cells. And so that is very interesting that you say that. And it's true, right? We have genes, we have cells, we choose what we put into our body as far as nutrition, but that environment, everyone's environment's going to be different. And if you don't have, it doesn't matter if you take 100 supplements a day and you give yourself every micronutrient you possibly need. If your environment sucks, the micronutrients can't get into the cell and the cells can't do their job. So you're wasting 100 supplements a day, right? And so that's so true. Like the environment is so important when you go back to cellular physiology, right? All cells have lipid bilayers. Lipid bilayers are how hormones, and things come into cells, right? So anytime you want to get something into a cell, it has to go through a lipid bilayer, through a receptor. And if you have a toxic environment, those lipid bilayers don't work, right? They're inflamed. The receptors won't open. You can't get things into the cell. So you can have 1,000, army members standing outside of a giant castle door, beating on the castle door. But if the castle door is rock solid locked, those army members aren't getting into the castle door, right? It's the same thing with your cells in your environment. If you have so much inflammation from, radiation or the food you're eating or lack of, whatever, it doesn't matter if you take every supplement in the world. If I give you IV vitamin C, if I give you whatever you need, if it can't get into that cell because the lipid bilayer is destroyed because of the environment, because we have so much cytokines and so much inflammation, we're not really getting anywhere, right? Because we've got to get into the cell to allow the cell to have what it needs in order for the cell to function. And so I think we miss that in medicine because nobody taught me that in school ever. And I kind of know this, but it's taken 4 years of integrative medicine of me trying to figure out what the hell is going on with my patients and why they aren't getting better to actually be like, oh, yeah, well, it's got to get in the cell, right?
Yeah. What we're wanting to do is we're wanting to get a name. And with that name, we know what to then give. I mean, it's back to that protocol. It makes it really easy. It makes it really easy to control. It makes it really easy to create an assembly line. And, but that's not what medicine ever was, nor was ever intended to be. Medicine, as it relates to the practitioner, it's a profession that's geared for those that are curious. It's geared for those that are servants because, what it means to be a physician is to actually serve. And so we must continue to serve our own curiosity of mind, and we must continue to serve our patients in that. The only bad question is the one we don't ask. And for goodness sakes, the patient that sits in front of us, we must ask every question, no matter the ridicule or counter or pushback we get, because that patient wants us to help us. That patient expects us to help them. And that patient demands us to reach outside the box to help them. And we as physicians, we must demand that of ourselves. And honestly, I think we must demand that of our profession. We need more of that. We need more people like you. We need more people like others that we know together mutually that are working together to reach outside that box. And that's how we change medicine. And that's how we restore it to what it needs to be. And it's getting back to those root causes. And that's going to help us for sure.
And we need patients to demand it too, right? So patients need to be outraged as well. When, they need to be angry at insurance companies, they need to be angry at our medical society and how we train doctors. They need to be angry at a lot of things. They need to demand something different, because what we have in this country is sick care. And what they need to say is we want well care.
Yeah, that's why these podcasts are so important like this. They empower patients. They empower them to be able to feel solid and confident in their perspective. So that then when they go into their doctor that is a naysayer, they go, well, are you aware of this study, of this study, of this work, of this study? And they go, well, no, I'm not. So that patient that's empowered has the capacity to take a control, to steer their own healthcare. And we need more patients empowered to do that. And the only way we can do that is through what you're doing, what I'm doing. And that is how they are steering their care.
Yeah. Education, good education, might not be medical society driven education, but it is solid medicine education. Yeah.
Scientific. Yeah, sometimes science and medicine don't always align.
Scientific cellular education. How about that? So
people talk about engineers. Basically what we do is we're basically just molecular engineers. That's really what we are. We apply molecular engineering, really. That's what we do.
And detectives. I tell my husband that a lot. Like, I feel like a detective sometimes, right? Like you're listening and you're trying to figure out what could cause this or what could cause that, or it's kind of cool. Okay. So I have a few pointed, specific questions for you. So I believe in IV vitamin C. I read a lot about it. I hear you talk about it. True or false? Do you think IV vitamin C, high doses, helps with immune system, helps with cancer? Like what, because I have some people who come in and say, well, my primary care doctor said you're crazy. I don't need vitamin C. I don't need to take high doses of it. It doesn't help anything. What are your thoughts on that? Especially if somebody has cancer.
Yeah, find another doctor if a doctor tells you that, because they don't know any science. We need more doctors having their heads in the science and not their head in the clouds or in the sand, for that matter, with that kind of statement. I think when it comes to vitamin C, it's one of those things, Cassie, that it is the flagship of integrative medicine. And so it's one thing that we must know it, we must understand it, and we must be able to teach it, because there's a lot of people that talk about IV vitamin C and they do not know what they're talking about. And so what happens is then conventional doctors don't understand IV vitamin C, and they'll go, see, they don't know what they're talking about. And you and I would go, yeah, you're right. They don't know what they're talking about. But it depends on what the focus is. Because people would say, well, just take oral vitamin C. I'm sorry. The pharmacokinetics don't work. You can't absorb enough vitamin C through your gut to be able to do that. You must achieve 1 millimolar of vitamin C in your plasma to get any cytotoxic cancer-killing effect. And you cannot achieve that with oral. Research has shown this time and time again. You may achieve 120, 200 micromolar. That's not 1 millimolar. And so what has to happen then, if you want to have a direct cytotoxic effect, is only IV. Now, when you give IV vitamin C, everybody's thinking about the cytotoxic effect. That is the direct cancer-killing effect. But then you have to think about, okay, well, if I give IV vitamin C, am I reaching a therapeutic level in the plasma that allows me to optimize delivery into the extracellular space that then achieves and reaches the tumor microenvironment penetrates and saturates the tumor microenvironment, and then penetrates and saturates all aspects of the tumor, that being normoxic areas and hypoxic areas. We don't know that series of steps. We do know the plasma effects. And so if we achieve 350 to 450 nanograms per deciliter, we know that in mice models that has the optimal cytotoxic cancer killing effect. But does that extrapolate to saturation in those other areas? We don't know. But here's the good news, or bad news, depending on how you look at it. In a lot of the medications out there from the conventional standpoint, they don't know that information either. So we're not in a different area. But typically that has to be dosed, not typically, it does. It has to be dosed based on weight. 1.5 grams per kilogram per IV for high dose vitamin C for a cancer killing effect. Now, that's cytotoxic, but that dose may need to be upped because you could have a high tumor burden, you could have a big body surface area, you could have a lot of inflammation, you could have massive deficiency. So there's lots of variables that go into what could affect that dose. But if you want to just stimulate the immune system, there's research that showed low dose IV vitamin C stimulates the immune system post-operatively and helps healing the recovery. Nothing to do with cancer, just healing the recovery phase of surgery. But if you want to go just in terms of stimulation of the immune system, you have to use that IV, but you can lower that dose. You don't have to go that high dose. And so you can lower that down to 12.5 grams to 25 grams. But what I always would do is basically start off 25, 50 grams, typically 50 grams, but dose that over many hours because everybody focuses on that dose and they forget about the duration. And that duration is equally important as that dose of vitamin C. And so this is what is important in vitamin C is, number one, what does the science say? Number two, what's your objective? What are you trying to achieve? And then how do you dose that in a way that delivers it in a duration that gives you that intended effect for as long as you can? So does vitamin C help in cancer? Definitively. Coupling it with radiation, coupling it with surgery, coupling it with chemo. There's a lot of probably regular docs out there that are just yelling explicatives at me now. But what is radiation? It's a pro-oxidative therapy. What is chemotherapy? In many aspects, a pro-oxidative therapy. What is high-dose vitamin C? Let me see, a pro-oxidative therapy. Now, people would go, well, that's going to be pro-oxidative to healthy cells. Here's where natural therapies shine. Their effects will be dictated by its environment. This has been shown in mouse models with vitamin C, with curcumin, with photodynamic therapy. The healthy cells, they don't take on that cytotoxic effect of vitamin C like the cancer cells. In fact, the vitamin C in the cancer cells has a half-life at 48 hours, whereas in healthy cells, it's 16. So the environment dictates the response. Just as in a healthy person, the environment dictates the disease, here in therapy, the environment dictates the response when we're dealing with natural therapies, not the targeted one-shot kill obstruction of a conventional therapeutic approach, but a natural therapy. It will target those abnormal areas and then protect and heal those healthy areas. That's the beauty of natural.
That is so cool. So you're telling me if we give somebody high dose vitamin C and they're a healthy cell, then the vitamin C is going to work for about 16 hours versus if it's a diseased cancer cell, it stays in there for 48.
Yeah, it's mouse. Now it's mouse model.
We're
looking at liver. Okay.
That is so cool.
The half-life. Yeah. So the half-life.
Yeah.
So that's where the dosing. So Reardon back in the early 90s, Reardon talked about when patients dropped their frequency to less than twice per week, that's where they saw the benefit really drop off. And if you look at that study, you go, now I see. So that's why really 2 times is a bare minimum, but 3 times is the best. 3 times a week, like a Monday, Wednesday, Friday, is going to be typically when you're treating cancer, it's going to be the best. And, when people go, we all get 50 grams vitamin C. And so you have a 5'2", 125-pound lady sitting next to a 6'6", 360-pound guy, and they're both getting 50 grams, and they go, I'm not really sure that I'm getting what I need. And the answer is that's correct. We got to dose it and dose it based on those basic pharmacological principles. And Linus Pauling actually talked about this. He actually said, look, everybody talks about the pharmacokinetics of drugs, pharmacodynamics of drugs. But when it comes to things that are natural, like vitamin C, they forget all these basic principles that, guess what, still apply.
So if you're giving somebody 50 or 100 grams of vitamin C, how long is that going to take them? Just so patients are aware. This isn't a 1 to 2 hour thing, people, just so you know. How long
Well,
is this typically going to take?
well, most of my patients would be 100, 125 grams. So those patients, again, it's based on weight, and you got to check the vitamin C levels. You got to check the plasma vitamin C levels as well, because that's important. And a lot of people will try to
In the
estimate.
opposite arm, right?
That is correct. That
In
is
the
correct.
opposite arm, people.
That's because if you're giving it in the same arm and you're checking it, sorry, it's going to be high. Yeah. So and you need to do it basically right at the end of the infusion, so as to see where your systemic level is. You cannot equate. I know there's a lot of people I respect that equate plasma glucose via actually a capillary glucose. They equate that to vitamin C. You cannot. The only thing you can equate there is an elevated level. So you cannot equate those.
Okay. But how long is that going to take if you're doing 100 or 125 grams?
I would typically dose that over 2 hours, but you could definitely dose that over 4. So I would try to keep the infusion rate at about 25 grams per hour. So I don't think you have to you don't have to necessarily go really, really slow. But if the patient maybe has an issue where they can't tolerate that vitamin C dose, then you just you could run it over 3-4 hours.
And you're just putting all of this in like a couple liters of saline. Is there a way that you dilute it 25 grams per half liter, or how do you do it?
Well, again, nothing works alone. So I talk about the stacking of therapies, which means, therapies work better together. When you talk about, phytocannabinoids, there's the entourage effect. Vitamin C with magnesium actually helps to keep that vitamin C in there longer. And so when you look at that magnesium, you need magnesium in there as well. So, you could put, vitamin C in sterile water, add in 2 grams of magnesium. Most people don't put enough magnesium in there. You can definitely put some vitamins, some of the vitamin Bs in there. But, for me, the vitamin C and the magnesium are the two most important aspects of that infusion.
Okay. So I'm not crazy. Vitamin C works.
No,
Yay. Okay.
The science tells us it works.
Yeah.
And experience tells us it works.
And if you're getting sick too, right? Like I tell my patients, when you start to get a cold, viruses, things like that, you can take oral vitamin C, but I tell them they're like, oh, I'm going to take a bunch of oral. It doesn't really work. You can't absorb enough from your gut. Like you need to get some decent vitamin C in an IV. It has antiviral, antibacterial properties. Same thing with ozone therapy. So that's the other thing I talk to people about, ozone and cellular tissue products as well. Certain cellular tissue products as well are antiviral and antibacterial, but same thing with ozone. So, a lot of people don't want to go out there on that limb of can you do ozone? Can you do cellular tissue products in somebody with active cancer? They take this stance of oh, maybe we shouldn't do that. But to me, ozone's been around forever. It's been around for a really long time. So ozone is when you take someone's blood out, for listeners, and you run it through a machine. It uses ultraviolet light to kind of clean the blood. You can add oxygen back to the blood and then you give it back to someone. So that ultraviolet light that you're using, depending on the gamma wave frequency, can be harmful or it can be helpful. And it can, there's research that shows that it can kill bacteria, it can kill viruses, it can do lots of cool stuff. So what are your thoughts on ozone? Yes, or you don't have to, you can say yes or no or pass, but
huge fan on ozone. Okay. Ozone, absolutely. Ozone helps with pain. Ozone's pro-oxidative. Ozone is hyperoxic. So absolutely, I'm a fan of ozone. Now, for me in the cancer arena, I usually kept it very simple. I didn't get into the 10-pass ozones, etc. We did do some, some high dose ozone. We did do some EBU, but we didn't do a lot. So ozone, I think, is one thing in cancer that clearly has indication across the board. But absolutely, I'm a big two thumbs up on ozone.
Okay. Yeah, so we have our EBOO machine coming. I'm super excited, but we're going to do all that as well. Not just for cancer, but I love it. I think it's amazing. What about so peptides? There's so many peptides out there. I'm a huge fan of peptides in the cancer world. I think there's a lot of positives for that. So you're a plus on peptides. Maybe like list a few that you think are great. Are you? I love glutathione. That's pretty easy detoxifier. NAD is great. I love BPC, although that's getting hard to get. I don't know in cancer. I mean, it helps with inflammation, but there's a lot of these, thymogen and a lot of these immune modulator peptides that make me a little nervous sometimes. I saw a lady today who's been on one of these immune modulator peptides for 3 years without going off of it. And I'm like, ooh, I don't know that that's a great idea, right? Because I think you're supposed to cycle these things. You want your immune system to be able to work sometimes. But what is your thought on peptides in cancer?
Well, I think it depends on, again, what's our purpose and what do labs tell us, and what's the person's immune system, because that's one of the things that I'm always looking to find out evidence of what is the environment, and so what do I need to do. I think if we just say, well, here's a patient with cancer, I'm just going to throw things on the wall and I hope it sticks and I hope it works. That's not going to work with conventional. That's going to not work with integrative, natural, or anything. So that process never flies. So I think if you identify that you have a suppressed lymphocyte count, low immune system, and you come in and you say, okay, I want to give thymosin alpha 1, okay, and I want to use that for a certain length of time, and then I want to then reassess that immune system to clarify, identify, is this indeed working? Because when conventional docs go, well, I'm going to put you on a blood pressure medicine because you have elevated blood pressure. Now, why are they going to do that? Because they want to lower it. Now, how do they verify that that has lowered and worked and they don't need to adjust the dose? They bring you back and they reevaluate. In the natural, holistic, and integrative world, that concept unfortunately gets lost on a lot. And that's unfortunate and that's not scientific. So we need to reassess and we need to pivot. I think when we're looking at something like cancer, especially when we're dealing, Cassie, with the more advanced degrees of cancer, stage 3, stage 4, which, it fits. I call it, they're a beast. It's an absolute beast. I hate it, but it's fantastic to see patients recover from it. They are my heroes. But in those patients, I don't know if TA1 in a sub-Q dose is enough daily, 3 times a day. I am more and more over the years, and this is why I'm working with Dr. Williams. I believe that we have to have an approach that is a paradigm shift in cancer. Cancer rates are just skyrocketing. And I mean, now you look at colorectal cancer, it is a disease of people under the age of 50, period. So the demographics are shifting all over the place. So we must pivot. Cancer's pivoting, it's mutating, it's ahead of us. We must get ahead of it. So I think taking peptides systemically or even into the tumor are going to be the better approach in the future. But we must give peptides as they are needed, not guesswork. Another one that actually has some pretty good research behind it is PNC27. But again, I have my concerns about when we're dealing with this advanced disease like stage 3, stage 4, are we getting enough? Are we getting enough into the tumor? And that's a question we don't have the answer to, Cassie. I love peptides, absolutely love them. People go, I don't believe in peptides. It's like, really, you don't believe in insulin? Because that's what it is. That's what it is. So I love peptides. Use them, use a ton of them. It's just, I wonder if with this shifting approach that we need to, with the systemic therapy, taking it to the tumor, the immune therapy, taking it to the tumor, do we need the same for peptides?
Yeah, I've wondered that too. And like, or do we need to take them in a different route? Inhale them, give them IV, different doses. But and some of these poor people with stage 3 and 4 cancer, some of these peptides, if used correctly, will help them eat. Will give them an appetite. will help
Yeah,
him gain muscle. I mean, so it's, yeah, I mean, everyone wants to use them to lose weight, right? So, just my caveat with that is if you're going to take a peptide to lose weight, go to a doctor that knows what they're doing, not a pop-up clinic, because everyone in the world can give you all these peptides now for weight loss, and then you're going to gain all the weight back if you don't do it correctly. So that's I saw 3 people today who came to me who have been on peptides, lost a bunch of weight, gained it all back. And I looked at all 3 of them and said, well, what was your muscle mass? What was your weight? What was your fat mass? How much protein were you eating? And they looked at me like I was crazy. And I'm like, nobody asked you this question the 8 months you were taking peptides. Nobody was monitoring how much muscle mass you had. Nobody was monitoring your protein intake. No. Well, no wonder you gained all the weight back plus, 20 pounds. So you have to know what you're doing, right? You have to know what the goal is. So you're a plus on the ozone. You're a plus on the peptides. I think you're a plus on the cellular tissue products. You're a plus on the IV vitamin C. So I haven't lost my mind. What about mistletoe? I heard you kind of talking about mistletoe, and I've just sort of started reading about that. So I know very little, but now I'm intrigued. So tell me just a little bit about mistletoe.
Yeah. So, mistletoe is not just for Christmas, right? It's not just to steal a kiss, right? Mistletoe, it's birthed out of anthroposophic medicine. And one of my dear friends, Naisha Winters, a naturopathic doctor, knows more about mistletoe than anybody I know. And she's a brilliant lady. But mistletoe is amazing because it depends on what kind of mistletoe you're talking about. There's 4 main manufacturing processes of mistletoe. But, a lot of people will focus on, mistletoe can actually help improve quality of life. Well, it depends on what mistletoe form you use. There's a form of mistletoe called Abnoviscum fraxini, which is, you can get it from Germany, but it's a very, very, very aggressive form of mistletoe. And you can actually use this for what's called mistletoe fever induction therapy. Now, this should only be done under the guidance of a physician that knows what they're doing. Just like what you talked about, going to a doctor that knows what they're doing. It's like somebody goes to a weekend course on hormones and comes back and puts up their shingles. I'm a hormone expert. It's like, yeah, no.
Yeah, I clean up all those messes all day long too.
Yeah, that's right. Clean up on aisle 3. So there, so many types of mistletoe. So I think that's the issue related to mistletoe is if somebody comes in and, they're just, they're cachectic, they're in a bad spot, they've had lots of chemo, the immune system's destroyed, and you're trying to get some therapies in naturally, holistically, and integratively and improve their quality of life. Something that's not high in lectins and viscotoxins, something like Visca, abeatis would be something very mild. Studies have shown really helps quality of life. But if somebody is, getting vitamin C, getting chemo, low-dose chemo, and you really want to augment that effect, you could actually step that up with Pini. You could step that up with Viscum Pini, with Viscum Molly, and then, of course, my favorite's Obnoviscum fraxini. But there's so many others out there. People look at mistletoe and say, well, I'm going to pick this one. I'm going to treat all these different types of patients. That would say, I'm going to pick 100 patients with blood pressure, and I'm going to treat them all with this same antihypertensive. And people are going to go, well, that's not going to work. But that's exactly what people in the natural world do in the treatment of cancer with mistletoe. It's a wonderful therapy. I do think it's a great therapy as an adjunct. So that means combined with other therapies. But here's what I would say on that aspect to all treatments, Cassie. They all work better combined with other therapies. The more we can lower the dose, the more we reduce the side effects, the more we get the entourage effect, the stacking therapeutic effect, the more we can attack the cancer and heal the body at the same time. And mistletoe really helps us to do that. Love it. Absolutely love it.
Okay. So now all these patients in my mind are blown. And we're all thinking, okay, so let's say that there's somebody out there listening right now that has, stage 1, 2, 3 breast cancer. And they're like, how do I go see Dr. Goodyear? And if I go see him, what does that process look like? Can you give us a brief synopsis? Do they have to have surgery first? Can they come see you right when they get a diagnosis? Just give us a little synopsis of what that looks like. Do they have to go to Cabo? Do they have to go to Mexico City? What do we do?
Right. So as we mentioned, I've been working with Dr. Williams for 5 or 6 weeks now. I was medical director for a couple of different practices for over 6 years where they could actually see me in person. So I am in a little bit of a transition right now, and that sounds kind of weird in this environment. But it what so what it's about is we have an office in Beverly Hills, so that's where they can be seen by myself. They can be seen by Dr. Williams, where the procedures are done. The procedures are done in Cabo and in Mexico City. We actually have a couple FDA studies that are ongoing. With prostate, actually with pancreatic cancer, and I think lung are still open. The prostate cancer is closed. So we're actually using integrative therapies, but we're understanding that there's a scientific structure that we can work within. There are partners there that we can work with to advance medicine. We don't have to necessarily upfront the industry. Now, there are times where we need to. But we have allies. We have friends there. And we can work with them to advance medicine for people. So they can find us at the WilliamsCancerInstitute.com. My personal brand is in a re-evolution, if you will. So we will actually be relaunching that very, very soon. I have people out there that I have, they're not my friends, that will I say. And I've had to rebrand myself and relaunch myself. And that will be coming very soon, where I will just be speaking my words about what I feel about things. That's on the website and the podcast, but you'll find me on all social media, Instagram, Facebook, TikTok. That's where you find me, open my mouth and tell you how I feel about something.
So we'll link all his stuff in the show notes to the Williams Cancer Institute. And then we will also link his personal Instagram, Facebook, all of his stuff. And then when he finishes rebranding himself, he will let me know and we will update all the links and we will repost some stuff with his new branding stuff.
We're right there.
Okay.
We're right there.
And then for my patients in Oklahoma City, if you are interested, I will connect you with whoever you need to be connected with. Have zero ego and want you to get better. And so I will get you in contact with him because he is way smarter than I am when it comes to cancer. So we will do that. But I'm really excited that you're doing this for people. I think it's awesome. I have a couple of patients that are in my mind right now that would probably love to see you. And at least, get a plan. Like somebody could just come to you and say, hey, I've seen a medical oncologist. I'm assuming they could come to you and say, hey, I've seen a medical oncologist. They want me to have, surgery, chemo, radiation. I'm thinking of breast cancer because that's what I deal with a ton. And before they did all that, I'm sure they could have a consultation with you and maybe get a different plan. And then they could just determine what they wanted to do. Is that what that kind of looks like? And I'm sure, just like when somebody comes to me, I'm like, yeah, you have 12 ailments, but we can start with the top 3 and we can go from there. We can attack it all. So I'm sure there's lots of options, but I just love that you took the time to come on here and explain this to people. I think that the C word, that cancer is so scary. And I hate when I see these patients that medical oncologists have got a hold of and just terrified and they haven't even, given them any other option. Like I see women with DCIS, right? Like these tiny DCIS tumors that get full mastectomies and chemo and radiation. And I'm like, what? Like what is going like that is the only option. And I'm like, is it like, really? Is it the only option with DCIS? Like a less than 1 centimeter DCIS tumor? This is the only option? Where, what the hell is going on in medicine? So, anyway.
Let me say one thing is that I do consultations, online with patients through biohacks. So, our great friend, Dr. Andre. So, so I can do consultations there. It's for the patients that have stage 3, stage 4, the really advanced cancer, where they're trying to decide between, okay, I need surgery, I need chemo, I'm not sure what it's going to do, I need radiation. What alternatives do I have that actually, here's the kicker, that actually are effective? Okay, are effective. Now, if there are people that are stage 1, stage 2, I could do the consultations there to steer them in terms of what's the best therapeutic strategies to help them, and that's through biohacks. But if they have that aggressive cancer that needs aggressive therapy, that's where the Williams Cancer Institute allows them to achieve, I believe, the future of cancer care today. But it's in those instances where that's necessary.
Okay, that's perfect. Yes, I know. So biohacks, we can link that as well if we need to on the show notes. But yes, that's awesome. I forgot. My patients in Oklahoma City, just get with me if you need it and I'll get you in contact with biohacks or with Dr. Goodyear. So thank you for blowing my mind and opening my mind and helping talk to patients about this. I think this is very beneficial, the educational part. I have 3 questions that I end my podcast with, so I want to ask you all 3 of them.
Okay.
So what is one food that you think is the most beneficial and why? If you have to pick one food, what would it be and why is it the most beneficial?
It's Brussels sprouts without a doubt. Just
Okay.
I'm part and parcel because I love them, but because they really help in the estrogen metabolism. Now you could look at many of the cruciferous vegetables and see that as well. But in terms of looking at the cytochrome P450 enzymes as it relates to estrogen metabolism, but it also applies to other hormones and many other things. But Brussels sprouts they're my favorite, and so because of the taste and I love them and their impact on estrogen metabolism, I'll go with Brussels sprouts.
Okay. Nobody said Brussels sprouts. I like that. What is one easy health tip that anyone can do that's completely free? And I want you to focus on like cancer prevention. So if we're trying to prevent cancer, what is one easy health tip that anyone can do that's completely free?
I'm going to step a little bit out of the box. And again, nobody talks about it. It's relationships. Find somebody that you love and somebody that loves you and somebody that you can do life with. And nobody talks about that. But let me tell you what, Cassie, the people that do well, they have that. They have that. Those that don't, they don't. And so I would say cultivate relationship. Reminds me really quick, sorry. There was an article I read many years ago where they were looking at couples that had been married 65 years. The purpose of the article was how they had become like one brain, left brain, right brain. But what in reality they found is that when they interviewed these couples separately and brought them back together, is that they had a daily commitment to the relationship. And that's what allowed them to get 65 years or plus. And so a relationship needs daily commitment, just like healthy living needs a daily commitment, but those are intertwined.
I really like that answer. I would also add to that, people, that you also need to develop a healthy relationship with yourself. So there's so many people out there who hate themselves or are mean to themselves or only say bad things to themselves. And it's really hard to be in a relationship with anyone and be a good companion into a relationship if you're not being nice to yourself, right? So buy yourself a flower, take yourself on a walk, say something nice to yourself, treat yourself like you would treat a friend. It took me until I was probably 35 years old to realize that. And it's really sad. I've always been really hard on myself. We're doctors, more, that's not good enough. That's not good enough. But once you are nice to yourself, it makes it a lot easier to be nice to others too. So
Agree.
Yeah. And then what is one thing you wish you would have known 20 years ago about your health prior to getting this, cancer? What's one thing you wish you would have known and done differently besides the relationships and besides the Brussels sprouts?
Yeah, because I've always loved Brussels sprouts.
Okay.
Maybe that's my body saying, you need these.
Yeah.
Wow. That's a big question. Probably, when I was playing football, I would say I would have eaten better. Everybody talks about food, but there's ways that you can, be strong, be big, and be healthy without eating 5 Big Macs in a day, which I did do during high school, just to put on weight. So I would say, being more committed to playing the long game in my nutritional strategy, not the short game. But then again, I was 16 and 17, so I couldn't see past Friday. So I would say that was it. But that really requires a level of thinking that's typically not present at that age. But with age, right, and experience comes wisdom, and so that's what I would say. Somebody would have
Okay.
blessed me with the wisdom to have eaten better to have put on healthy weight, not to just have eaten calories to put on weight.
And hopefully somebody hears that and we bless them with that education. So Dr. Nathan Goodyear, thank you so much for empowering the next generation of integrative, cancer care, because I think what you're doing is awesome. And I know sometimes stepping outside the box is hard, and, you get a lot of hate sometimes, but I know you're doing it for the right reason. I'm really happy to have met you through biohacks. I love, to have people to collaborate with and to have people to send patients to. So I applaud you and appreciate you for doing the work that you do. I'm so glad that you do it. And I'm excited to follow you and see all the awesome things that you learn about cancer care. So I appreciate it.
Well, first of all, thank you for having me on your show. Second, it's always great to meet like-minded individuals that are working to change medicine for the benefit of the patient. And we can't do this alone. I mean, there's no one person that has the answer to cancer. There's no one person that has the answer to healing or wellness. We must work together. And it's in power, in numbers, that allows us to actually basically act as a buffer to all those naysayers. At this point, I'm 53. I've been here, done that. People will call me names. People will say things. At this point, I don't care. It's the patient. Let's focus on the patient. But the more people we have, the power in numbers as practitioners, it's power in numbers with patients as well. And so what you're doing with this podcast, I commend you, because it's building that next generation of patients that are empowered to control their own healthcare. So thank you what you're doing. And thank you for having me.
Yeah. And hopefully we're empowering providers to step outside that box too, that have thought about it. I know there's a lot of you out there that think about it and you're probably not happy, and you realize what you're doing isn't making people better. So just know that there are other people out there that are doing it, although it's scary, and that there are resources you can find. I'm working on some online, educational stuff, but just, remember why you did it, and make sure that when you go to sleep every night that you sleep well. That would be my advice. So
don't fear, just do it. Don't fear, just do it.
Just do it. So if you guys enjoyed this podcast, please make sure that you share it. Find somebody to share it with. I know that there's somebody out there that that would benefit from listening to this. So please share this with your friends, with your family. Make sure that you follow us on wherever you get your podcast. Subscribe so that you get all the podcasts, and then make sure that you check out Dr. Goodyear's social media as well. He posts some really awesome stuff. I appreciate your time, and I appreciate, you being here. And so we will see you next week. The information presented, including any materials discussed, referenced, or linked within this podcast, are for general educational purposes only, not the practice of medicine. No doctor-patient relationship is formed from you listening to this podcast or utilizing any of the information provided. I am a doctor, but I am not talking to you as your doctor. The information provided is not intended to diagnose or treat health problems, or take the place of the professional medical care provided by your doctor. If you are experiencing any health problems, including problems you believe have been touched upon in any respect within this podcast, you should consult your doctor about the problems without delay. You may ask your doctor whether he or she believes the information I have provided would be helpful to you, but you should still consult your doctor immediately and follow his or her medical advice as your treating physician. I'm just here to provide you basic knowledge about the issues we discuss so you are more aware of them and can better discuss them with your doctor. That's why we call it Back to the Basics. Join me on the next episode as we continue our journey.